Good morning, everyone. Thank you for joining us. I will begin by respectfully acknowledging that the Institute for Healthy Living and Chronic Disease Prevention at the University of British Columbia, Okanagan, is situated on the traditional, ancestral, unceded territory of the Syilx Okanagan Nation. I would also like to recognize that you are joining us today from many places and acknowledge the traditional owners and caretakers of those lands. We're using closed captioning today, and the closed captioning box can be moved to your preferred place on your screen by clicking, dragging it, and moving it to wherever you would like it. Or if you would like, you can turn off the closed captioning by selecting the Hide Transcript button that's on the menu bar. Today, we're going to be using the chat box, and we're encouraging you to type your questions or comments into the chat box during the presentation. The questions will be read at the end of the presentation. I am very pleased to say that today's event is a Research to Practice webinar, and it's co-hosted between the Institute for Healthy Living and Chronic Disease Prevention and our amazing partner, the North Okanagan Hospice Society. Clara Dick is the Education and Resource Leader at the North Okanagan Hospice Society. And thank you very much, Clara, for joining us today and your partnership.
Thank you, Jennifer. As you did share, my name is Clara Dick. I work at North Okanagan Hospice Society, also known as Hospice House in Vernon. It's my pleasure to introduce our today's speaker. Dr. Hsien Seow is the professor, McMaster University, and the Canadian Research Chair in Palliative Care and Health Systems Innovations. He is speaking today about building palliative care capacity by engaging generalist providers and patient and families. Dr. Seow, I'm turning it over to you.
Thank you so much, Clara and Jennifer. Welcome, and thank you for having me. I love the West Coast and BC, so I will vicariously imagine that when I look out my window, which is sunny today, that I'm there instead of here in Ontario. But thank you for taking time out of your day to have a conversation, and please use the chat bar. I have the sense that most of you are volunteers and members of the public, and not so much healthcare providers. So I'll try to gear some of my remarks to that. But please feel free to use the chat bar, and we will probably answer questions at the end, but I will at least see how active it is. Okay. So I want to just share with you how I got into this field of palliative care, and I can, I know that obviously you're joining this webinar, so you might have some idea of what the words mean and aren't frightened by them, especially if you're a volunteer with the Hospice Society. But my connection to this field started when my mother, who is pictured there, obviously I'm the baby, was diagnosed with cancer, breast cancer, and her name was Swatine, which means snow pearl in Chinese. And she, was diagnosed, she felt the lump, but she didn't think it was anything, and sort of took a while to get seen. And that started our whole cancer journey. There were highs and lows. There were years of, treatment and then remission and then recurrence. But I think the thing that stood out was we really didn't know what to expect. We really just were, it felt like a roller coaster. We were just along with this journey. And as a family, as a unit, and our extended families, we're just going along for the ride. We didn't know what to prepare for. And even though near the end, I guess I can say that now, she was getting frailer, the treatment was stopping. We just kept thinking, or we're told in some ways, the signals we were getting was hope more, pray more, be more positive, do more things so that she'll keep living, so that she'll want to keep living, and I'm not sure we really had the closure and used the time that we would have looking back. And she died in the hospital, even though, I, as a person in the health system, she had been there for weeks. It would have been quite a lot of, it's not surprising that happened, but we didn't know. And I think why I got drawn to this work was I wanted to change that story for other people. And the thing is, I got into research, and my mother died over 30 years ago. And when I meet people, patients, families, providers, and hear their stories from my qualitative research, they tell me the same thing, that I wish I had known that sooner. I hear very similar stories of people not knowing what to expect and just feeling like they're in the dark the whole journey. And so it really led me on this idea that we still have a long ways to go despite all the advances in medicine. And so I set out in my research career, and I really tried to think about this idea of how do we increase access to palliative care? How do we get more people to get it? How do we get it to them earlier? And perhaps these are things that you're connected to either as a volunteer or in the public of wanting to share this philosophy of palliative care to more people, because perhaps you've seen the benefits of that. So I did work in policy. I've done stuff in administrative data, looking at home care support, looking at hours of PSWs, how does it save money, what are the optimal measures, all these kinds of things. And yes, maybe they've made some difference, but what, really what happened was, policy is so big, but we don't have enough home care workers to provide that care. I mean, really, community care is really hurting. And then I focused a lot on provider education. So we've done a lot of training on what are the principles of a palliative care approach to all kinds of different nurses and doctors and specialists. We've done work on trying to build primary care teams. All of that is important, but I don't think they feel the urgency that patients and families do at the end, because too many people, and the data shows this, we still hear the same story, like progress is slow, and it's frustrating on some levels to connect the research world, the academic world, which maybe I sit in, and policy world, with the front lines, which perhaps maybe you're feeling more. We would still read in the newspapers how the patient experience is still forgotten. The family experience is non-existent. So what can we do? And this is really driven home by just the stat, just saying that even though all the things we've done in palliative care, half of Canadians, well, this is an Ontario study, but it probably translates to all of Canada, but half of people who die don't get any palliative care. And when they do, 40% get it 18 days or less before they die. So it's very late. They're getting it very late if they get it at all. And I think it's partly because there is this trend, or there has been this trend to think that palliative care is a specialty only provided by specialists. And it's really been, the focus of my later work to say palliative care is an approach to care that is everyone's business and does not only something that's given at end of life. And it feels like this, I'm going to put this little video up here, where, if Lucy and Ethel are the palliative care specialists, we just can't keep up. The healthcare providers cannot keep up with the patients and families who are on this conveyor belt, coming through, and they're just flying off. They're not getting person-centered care. I mean, they have no time to spend with any of them. So really the question is, what are we going to do? And so I will just share, and I see the question in the chat box, but really what the rest of my talk will be about is maybe about 5-6 years ago, we made this major pivot. It was before COVID, but before pivot was a buzzword, but we realized that we and my colleague, Dr. Samantha Winemaker, the two of us, she's a palliative care physician who works in patients' homes. We had spent years doing education to healthcare providers, but we didn't know what that looked like. What does that education look like for patients and families? And we just made this pivot to bring our bring our knowledge upstream and give the power to the patients and families. So that really changed my research focus from this idea of increasing access to palliative care to more people and earlier, to how do we improve the patient and family experience? And that little twist, thinking of who the actor was as an agent of change, changed so much, and is really the journey that I want to share with you. In other words, the focus wasn't on more Ethels and Shirleys doing more, knowing more. It was on how do we get those chocolates on that conveyor belt earlier in the process so that they could have agency and figure out how to, get the best experience possible so that they could find their box and get their bow and get the right, decoration and get what they need and not be at the whim of the people at the end of the conveyor belt. And so what I want to talk to you about for the next little bit is this Well, it's a social movement, but this project really called the Waiting Room Revolution. You see, what we did when we were sitting having coffee going, what does it look like for patients and families? We can't just provide this information. This information belongs to them. We thought, oh, it will be easy. We will just go up and just take our dog, our food truck, our dog and pony show and go upstream and say, hey, look, we have a lot to offer. Don't you want palliative care earlier? Don't you want early palliative care? And patients and families were like, no, no, thank you. Our food truck line was empty. People heard, patients and families heard early palliative care as giving up on them early, talking about death and dying early. They didn't hear the benefits. So that was learning for us. The tools that we had couldn't just be just sort of trucked along as is. So we had to really think of all the positive stories that we had heard and the many, many not so good stories that we had met, and think of what was the difference between the two. What's the difference between this idea of a good death or a better death versus a beautiful death versus ones where it wasn't so great and had complicated grief, and try to deconstruct this idea of what is a palliative approach to care. Not a palliative care specialist, I know what they do, but this ethos that the care that we provide, which we call a palliative approach to care, it's a philosophy of care. What are we actually doing? How do we operationalize that? And we deconstructed that. And then we had to think of how do we put that into action steps or a roadmap so that patients and families could be able to leach out this approach without the labels. And that's what we did. It took us a bit of time. We co-designed with patients, families, and providers, but we came up with 7 keys. So this is going to be relevant to particularly to the public who are on, the person who asked that question, but also hospice providers, but really anyone. It is the 7 keys to navigating a life-changing diagnosis, not the 7 keys to, have a good death, because we realized to improve the end, we had to improve the beginning. And so these keys are applicable early in an illness because they are the philosophy of palliative care. And the first key is called walk 2 roads. It is the idea that hope and pre-planning for the future or thinking ahead can coexist, and hope for the best and plan for the rest. Not plan for the worst, we're planning for the rest of the journey and knowing what to expect. Planning for the rest does not betray hope. In fact, hope evolves. Hope grows stronger when it is based in reality, in realistic facts of what to expect. And sometimes there's uncertainty, but we can understand the true nature of that uncertainty. Another key to having a better illness experience is to learn how to zoom out. These are skills that we're trying to teach patients and families how to do, so they could be the advocates for the best care. Yeah, okay. So zooming out is this idea of what is to know. We're so zoomed in on the blood test and the next thing and the next appointment and the results. We often forget to or know how to zoom out to the big picture of the illness and to understand the storyline, because every illness has a known beginning, middle, late, and end stage. It's the pattern or the natural history of a disease. Everyone has a different timeline, but the storyline for your particular disease is well known, and we can leach that out. So that serves as your roadmap and your anchor points, the milestones or bus stops along the way to know what to look for and know what changes mean in what context. The third key is to know your style and to recognize that you are who you are, and each of us bring our own set of coping mechanisms and styles and personalities to our life, and that is most likely going to be amplified when the disease happens and for those around you. And so knowing your style is a way to gain back power because you're not beholden to only the disease. Your style can influence the way the experience is going to play out. And you can lean into that and gain information. If you imagine how someone you love, or like, for example, my father, I know my father's style. And if I thought he ever got sick, I know what challenge, where he will be strong, what he will need. If someone doesn't like to ask for help, well, don't offer, hey, let me know when you need help. They're not going to ever ask. You're going to need to be more, direct and make it hard for them to say no, or just show up with what you're willing to offer, for example. Okay. Customize your order. This is the idea that while we can't, ask for anything in the world, we can customize the choices that we make that are based on our values. We need to bring our values what's important to us forward. Don't wait to be asked, because healthcare is a conveyor belt. It is a sort of a wheels and a cog. And so it is up to us to bring our voice forward to say what's important to us and use all the opportunities where we're being asked to make a medical decision, not just about how you want to die, but how the treatments and how you want to live. Pull that, consider that against what your values are, what's important to the person or the family if you make decisions as a family, so that you can tailor your experience. That is how you will maintain your sense of self throughout this whole journey and not feel like you don't recognize who you are. And you will choose care or make decisions that are important to you. Again, not just medical decisions, but life decisions, because you're still living until the moment we die. The ripple effects is the idea that nobody journeys this alone. There is an inner crew, we call it, often the family, but it could be a chosen family, who will also have a parallel illness journey. And they too need to know what their role is, what that entails, and get support and knowledge of, be as educated as they can about the illness, what to expect, and ask for help and what that looks like. Connect the dots is just the idea that no matter what system you live in, it's not perfect. No matter what EMR they're offering, it will never have all the information you need, because the patient, their inner crew, has vital information about what's happening and what's important to that person, and they need to connect the dots in the system. So somebody in the team, whether it's the patient or a loved one or there needs to be a manager of the team. And their role can be big, it can be small. There are ways to track information, but that's how you will have the glue to have more integrated care. If somebody is that role, don't outsource that and think someone's got your back. And lastly, the biggest key is to invite yourself. Don't wait to be invited to the conversation. You can invite yourself to talk about things that are important to you, and in a way that can be respectfully assertive. And don't be afraid, you'll be labeled a bad patient. No, you're asking real questions that are about your life and that are the most important to you. And so you have to be brave and be bold. Okay, so I'm going to pause here just for a second to just say these keys are really the fundamental philosophy basis behind this idea of a palliative approach to care. But the innovation is that we were making it in language that patients and families said, we can do this. This doesn't scream death and dying to us, dying and death. And we feel like these language would invite people to have different conversations with their healthcare providers. And these metaphors are really activating patients and families to use these words so that they can initiate the conversation with their providers. Doctor, can you help me to zoom out? I want to understand the big picture of my illness. Am I at the beginning, middle, late, or end stage? When you get that information, you will have more information to make better decisions. That is part of what palliative care does. Okay. So when we sat on these keys and we looked back, we said, okay, these keys, if we did this, if a person, and we've heard of stories of patients and families who did some of these or all of these. Now, they didn't call it that. We came up with those metaphors, but essentially they were doing that. We realized the result was they were more hopeful, actually more hopeful. They felt more power. They had a better illness experience. They were more informed, which led them to have more choice and control, and they had care that matched their values. And if you look inside this orange circle, you will see these are things that every person who's interacting with the health system wants and should be getting, but we don't know how, really. That was the whole point of the 7 keys. It's not about just dying well. It's about living well, even up to the point of death and beyond. Beyond being grieving. I'm not sure what happens beyond, but maybe one day that's another piece of research. But the impact wasn't just about, the impact of this wouldn't just be for patients and families, but it would be for providers. Providers can use this language and they feel better about the care. There were impacts to health systems and society as a whole. So we realized this was not a research paper. This was not an infographic this was a social movement. This information on how to leach out the best care possible belongs to the people. It is the way we can change the power imbalance so that patients, families, of which we will all become, or maybe are currently, to get that power back and not leave everything up to, well, a broken system, an imperfect system that's trying its best, no doubt, but has so many other things happening. So now that we realized we had the social movement, how are we trying to spread it? A social movement being this revolution, this idea where that, like, I don't know, hashtag Me Too or Black Lives Matter or, guns, not guns everywhere, but the, Mothers Against Drunk Driving or the, guns every town, everywhere or something that's against guns. Just all of these are social movements where individuals can take action and charge, where it isn't, it can happen everywhere by spreading things that people can do. Okay, so how are we spreading the movement? Well, we needed to give the movement a name. And so we called it the Waiting Room Revolution. Why? Because we realized it was in waiting rooms, in hospitals and clinics, everywhere, that it was where patients and families felt helpless, worried about what news they were going to get. Was it going to be good news or not so good news? There was no power there. And if we had a waiting revolution, we would flip it on its head, where patients and families would be armed with the knowledge of these 7 keys, would know what to ask so that they could take charge. Whether it was good news or bad news, they would know the questions to ask, to know how to formulate a plan so that they could take charge of their illness and move to the front seat and be activated. And not just in physical waiting rooms, but in the metaphorical waiting room of not knowing where they are in their illness. So anyway, we came up with this metaphor, another metaphor, called the Waiting Room Revolution. We have a website with the name waitingroomrevolution.com. And if you join and you click onto that website and join, you will find all our all our products, I guess, all the things that were under the umbrella. So the first thing that we did besides the website was we created a podcast. We did a podcast because it was the fastest way to get this information out. My host, Dr. Winemaker, and myself, we were ending up doing lots of talking by phone, and we're like, let's just record ourselves. Let's try to understand, how do we teach someone what are the 7 keys and how to do it? So season 1 of our podcast, however you get podcasts in every platform, you can find the Waiting Room Revolution. And if you go to season 1, you will listen to our story and the 7 keys, and it will tell you how to do it. And we have a patient story in each one illustrating that key. We didn't know how popular this would be. This, again, was a little project, us talking, testing it with patients and families, but not out in the public. But we had amazing response. These are some of the reviews on our podcast. Like, I binged the first season in a week. People talk about listening to us when they're walking and recommending it to their friends. It's an essential listening for anyone with a serious illness. And we even had a clinician saying it changed their perspective on how they approach their own patients and families, because they will be them too. But how do they talk about this in a way that's not scary? How do we make this idea, the philosophy of palliative care, accessible upstream early in an illness when we're not thinking about the death and dying, where we want to balance hope and planning? Okay, so these were just some of the things. And they kept saying, keep going. So we did. And what we heard from some of the guests on our podcast, particularly healthcare providers, is they were using this language in their practice. Like, they would change, instead of saying hope for the best, plan for the worst, they would start saying hope for the best, plan for the rest. And that changed the kinds of conversations they were having with their patients. Patients were asking to zoom out, and they knew what that meant. And now they could talk about illness trajectories and draw the picture and say, this is what we have, and what do I expect in this stage, and how will I know when I'm in that stage? It led to those kind of questions, instead of, do you want palliative care now? Oh no, you're not there yet. Okay. And we kept going and going, talking to people all around the world, UK, Australia, the States, Canada. We've talked to many people, not just healthcare providers, but experts in all kinds of things, patients, families, veterinarians, social workers, all different kinds of people who are connected to this idea of better patient care. And we're now in season 7. Let me think. We just had a patient last week, and today is when we drop our new episodes. We have someone from the U.S., WellSpouse from the U.S., which is an organization specifically for caregivers. So we have 5-star ratings. We're ranked in the top 1.5% of global podcasts. We have over 90,000 downloads in over 82 countries. I mean, it's pretty exciting that this little podcast, which we film or record it, was in our closet. So now it's this is exactly where I do my podcast, just like this, in front of my computer, sitting up with this little mic here. $80. So for $80 on Amazon, you can record yourself too. But it has become the beginning of our movement and connected us with many people. We also joined social media, which Sammy and I never did, but we felt it was important to hear from real people about whether this works. And social media was a place, A, to get our message out, but also where people really tell you what they think right away. So we had, like a living laboratory of these keys, these exercises, these phrases, our ideas, and if they would work in real life. We've been on other people's podcasts, and of course we had our own. Sammy's on TikTok, if that's a thing. She makes these videos in her house, which I do not do. I just, but she's very brave like that. But it has been an interesting experience to spread our word. And this is what people have said. It's taught them to not be afraid. They asked some of our questions for the first time. It was powerful. And it was a way to give them back power and to take things into their own hands. So again, this was the hardest part of what we had to do, was to make this idea of palliative care, a palliative care approach, which is scary and sad and depressing, into something that was hopeful and powerful and empowering. And we did that by deconstructing it and moving it upstream. Because when you get to the end, there is not much time to do a lot. We have to change the whole experience from the beginning. And then the story will be different. If you sign up to if you go to our website or sign up to our listserv, you have access to a one-pager of the 7 keys with a clear action, a simple action of what to do. So if that's something you could check out if you're interested, and download or follow us, just as a reference for yourself. And you can also, of course, listen in depth to each episode, which was, season 1 was like 40 minutes or so. But we're most excited that we just published a book. Let me see. It's right here. It came out 3 weeks ago. Hope for the best, plan for the rest. 7 keys for navigating a life-changing diagnosis. We're very excited about this. It is a guidebook for patients and families. Providers can read it too, but it's really directly to patients and families of what to do. It is a how-to guide when you become this thing called a patient, or this thing called a caregiver, or family caring for someone. Nobody taught us what to do, what to ask, what to know. And so this is how to hope for the best and plan for the rest. We talk about the keys. We talk about, the late stage of an illness too, and all the different parts of it. It's an ebook, an audiobook, and it just came out 3 weeks ago, but the reception has been pretty great, and it's available everywhere you buy books, in bookstores and online. Hope you check it out. It has been a lot of work to do that. But more than that, it is a really, the podcast was only one way to get this information out, but the book was something that we thought more people, like my dad loves me, but he doesn't listen to podcasts, and he is definitely not on social media. So, it took us years to teach him how to use text. So a book he can get and he can read, and you read again, and you can pass it to your other people in your family so that you can be on the same page. Anyway, these are some of the reviews. Palliative care journals read it and said, we don't frame it as palliative care, but it really is a love letter to palliative care. So we were excited about that, because we were trying to change the language around this and not make it so scary. But we really cared what patients thought. So this is a patient. He's a lung cancer survivor. He has been on our podcast, but he said reading the book reduced his anxiety and increased his control over his future. The anxiety came because he would have scanxiety. So every year or every 6 months, he has a follow-up appointment. And around those times, he would get extremely anxious. He said, it's like my anxiety was off the roof, off the charts. He said off the roof, I think. But when he started using the keys and zoomed out and drew the map and had different conversations with his oncologist, he knew what the plan was. He knew what to expect. So even though he will die of lung cancer, and he knows that, he feels great now, he's on immunotherapy. But when that time comes, he knows what to look for and what's going to happen. And once he had that plan, it increased his control. And now he's living his best life. He's an advocate. He's traveling all over the country. He was just in Singapore. Anyway, you can follow him on social media, but this is the power that we want to give back to people, rather than just being scared of when is this thing going to get worse? This is Sue Robbins, from BC, and she is a caregiver advocate, and she talked about hope for the best it's about what is in our control. There are things outside of our control, but this is about what's in our control. And it's not just for patients, but caregivers and professionals. And her dream was patients, caregivers, and healthcare providers read it and now spoke a new language. And she saw that as the way to get person-centered care. And I agree. And we are targeting patients and families well, because as I said, we have been doing healthcare providers for decades and moving the needle, but slowly. And I think the healthcare system will only change when we come to the system, we being patients and families come to the system, or citizens, different. We come activated, asking different questions, and demanding change. That is what's going to change the health system, in my opinion. This is a real person who we've never met, but on Twitter, he, 2 days after a book came out, he posted reading it saying, I'm a few chapters in, and it's a must read for folks. He has stage 4 colon cancer. And then on his social media, he talked about he was about to have an appointment with his clinician, and this was the next post. I just had a good face-to-face with my oncologist. We talked about zooming out on the big picture, and he's leaving today's appointment with a better handle on what's likely to happen next, where I am in my life with my cancer, and a plan. So this is how the language, the metaphors, it is palliative care, but it's not scary, and they're able to implement it right away. So I hope that people find the keys either through the one pager, through the podcast, through the book, in different ways that, that they find easy, or on social media, to try to recommend. You can share it to people. If you get it and like it, please rate and review it. That's one metric that's we're trying to grow right now. If you are on social media, if you're not like my dad and this is your thing, you can always follow us. But mostly we care if the keys are helpful to you. So, email us or let us know what you think and how we're going to use it. And we have a whole plan on how we're going to spread it. But the key is that this thing, these keys, this revolution does not belong to me or my partner, my colleague, Dr. Samantha Winemaker. It is information that belongs to the people. And we will only see real change if they take it into their own hands. If you take it into your own hands and implement it in the places that you have, or spread the word, or come to the system different. So, we are looking for ways for people to be part of the revolution, and they don't need our permission. We're giving away this information in different ways and take it and adapt it. So this is an example of collaborations. Like Palliative Care Western Australia was redoing their caregiver book, their patient caregiver manual. And they said, can we use your keys as the opening chapter so that we can introduce this idea in a non-scary way? We said, absolutely. So this is a screenshot of their new book, of their new sort of booklet, which I think maybe hospice societies. This is an earlier version of our one pager, and an Indigenous group in Australia, the IPEPA, it's called, the Indigenous Program for the Experience for a Palliative Approach, said, we like your metaphors, but we kind of want to change them. We like the keys, but we want to change the metaphors. So we said, absolutely, go for it. So they use, instead of walking 2 roads, they talk about swimming against the current, which might change depending. So you have to change your swimming. And they talk about zooming out being like seeing differently. So anyways, they use different metaphors, but the keys are the same. So we said, absolutely. So our hope, if people, wherever you're at, you can take these and use it. We just partnered with Health Canada because they have some funding for a palliative care approach. And they said, 7's too many, Sam, but can we what would you put in a doctor's office so that patients would know what to ask? So we said, sure. Here are 3 questions every person should ask. What's the nature of my illness? What can I expect now and in the future? And it says, how can I prepare for what next? But it's really about what's important to me and how do I bring that forward into my illness. So this is free on the Health Canada website. I think there's a link there, but you can just Google it, or and we are about to embark on a campaign for providers to put it in their offices. But this can be something you can use, to go to an early appointment with. This is the palliative approach. It's leaching out the information about your illness without using the labels. So even if they say, oh, you're not palliative yet, you can say, that's fine, but can I please understand what's the big picture of my illness? This is important to me. I need to know that today. And we have a provider version too, which helps providers to understand what to think about when a patient asks some of these questions. So that's another tool that's on Health Canada's website too. So we have given a bunch of these talks, and we have learned that we should often pause here for people to potentially think about some of the ways that they might want to be involved, if you will. So we have a little QR code. If you would like, you could just snapshot it or whatever, QR it. I don't know what the verb is there, but it will just list some of the ways that you may want to take action for yourself, really for yourself. And at the bottom, the second question is it just asks if you would like to join our listserv. You can do it there, or you can go to our official website, waitingrevolution.com, and join. But I thought I would just keep a moment here to let you know that this is an opportunity here. to let us know your interest. We often follow up with people because we're trying to spread the revolution. So we want to know where people are at and what they're interested in. I think this is my last slide, and I can go back to questions. Oh yeah. So I just wanted to say, this is this is sort of the last piece, but I just wanted to say, and then I'm happy to go through questions. I guess I talked too fast. Sorry, everyone. I got very excited. You can see why we lead a podcast. There's no dead air time. But this was last week. We actually interviewed a patient on our podcast. His name was Stephen, and he had lung cancer. And we interviewed him a couple times over his journey and of how he was using the keys, so that we were trying to get a real life story of someone using the keys, what information they had, what other information they needed, and coach him along of how he could ask, and just his story. And he passed away in September, a couple weeks ago, actually. And this is what his wife wrote to us. She said in an email, and we have permission to share it, of course. And she said, finding the podcast and book changed the way we lived this past year and how we prepared for the future. Before, Stephen was scared to ask questions and didn't know what to expect of his cancer journey. And as a caregiver, the book and podcast helped me realize that I needed to ask the important questions while I still had the time, not only from the doctors and palliative team, but also to make sure I knew what Stephen's wishes were all along the way, so that I could help navigate, advocate, and honor the way he wanted to live and die. So I feel like if we do this right, this is the story. We're going to change. We can't change the illness, but we can change the experience. And I think anyone involved in this work, either as a provider, a volunteer, or a patient or family, it's about living, and it's not about the dying. And we know palliative care can help do that. And we just want it everywhere. And the way to do that, hopefully, is through this waiting revolution. That's one of the ways, and you're all invited to join. So I'm looking forward to some questions, and hopefully this was some informative a little bit.
Thank you, Hsien. That was very informative. And I appreciate your energy. I can hear your experience with podcasting in the background. I was nodding and my hands were going. I was like, oh, this is so exciting. But I'm like, no, you can't talk yet. So now we all get to talk. And there's some comments in the chat. Just ordered your book on Amazon. Can't wait to read it. That's from Kathleen at BC Center for Palliative Care. Diane is going to order your book, and she's looking for a signed one from you. So that's lovely.
We'll actually be in, we'll actually be in, I know it's not, it might be close to some of you. We're actually going to be in Canmore next week.
Okay.
Tuesday, Wednesday, Thursday, Banff and Canmore. So I'm not sure what region Okanagan, and it's a little bit dry, but for anyone who's in that area, we will, with the Bow Valley Hospice Society, they have a bunch of events there. So we're flying out that way. And so I don't think Diane lives there. I recognize her name, Diane, but I'm not sure you're there. But I would love to find a way to connect and sign it for you.
Yeah, lovely. I have a question. I'm going back to the 7 steps and customize your order. In it, I have the book right here, everybody, fresh off the press. Here we go. Oh, it's still blurry. It's because of my my camera here. In it, it talks about the dignity question. Can you tell me a little bit more about that?
Sure, yeah. Dr. Harvey Chachanov created this whole program of research called dignity therapy, of like, what does it mean to have personhood and be seen? And one of the products of that is the simple question. The thing that has spread the most of all his work, it's a whole intervention, was the patient dignity question. A single question, which is, he coaches or teaches providers to say, what do I need to know about you, the patient, to provide you the best care possible? Okay. And the way to, so they coach providers to do that, to invite people, and it's often palliative care people on the palliative care ward. And so what we have done with the waiting room revolution, if you can, as an example, is we said, patients and families in the book, you don't need to wait for the provider to ask you that. You can go to the doctor and say, this is what you need to, or nurse or healthcare provider, and say, this is what you need to know about me to provide the best care possible. whether
Yeah.
that's your religious beliefs, your culture beliefs, that you are a survivor of the residential schools, or, I make decisions with my spouse and she's really the manager, and you need to know that about me to provide the best care possible. So don't exclude them. They always need to know what's happening, because they're making everything happen, or whatever it is important to you. Like, my dogs are so important. I want to be at home, whatever, and it might change, but don't wait for them to invite you. You bring it forward. What's the most important thing to be? So that's just an example of how you can customize your order, bringing your values forward, because your values, what's important to you, can then shape the decisions you make. And when people think customize your order, they might think it's advanced care planning, and then they might think it's about code status, and is it about do not resuscitate and feeding tube. But no, those are very, very, very like in the weeds micro decisions. I'm talking higher level. Like, it is really important to me that my children are involved in this, because they're still young and I want them to see what this looks like, or that they don't know, or whatever it is. Like, that will shape all the decisions that you make, not just about the medical ones, but about how you want to live this time. And it could be years. It's often years if we do this right. It isn't last weeks and days. It's months and months and months, and sometimes years. So there's a lot of time to talk about.
Yeah, there is. And I'm just, as we touch on these subjects, it often can bring up a sensitivity and our own personal stories. And we have somebody sharing a personal story here in the chat. So I'm just holding a little bit of space for Catherine, saying, I'm almost in tears. This information could not have come at a better time. This revolution will be a huge benefit to my family as we go through the path of my sister's illness. So, Catherine, just sending some care your way. And I'm really glad that you have access to these tools. Do you have any comments, Hsien, about how families have used these tools in their journey? Like, any examples?
Yeah, totally. Thank you. Yeah. Catherine's first comment is like her sister was diagnosed with an advanced liver cancer, it says, and when would be a good time to connect with palliative care? So my answer to that, really in the book, this is what we face on. This is what we face head on. Because if you went to your doctor and said, hey, I think when should we connect with palliative care? We often hear things like, oh, well, you're not there yet. You're not ready there. Let's not worry about that now. You're doing so great. So there's the part of toxic positivity, which the antidote to that is, no, excuse me, I would like to walk two roads. I want to hope for the best, and I hear you, but I also want to plan for the rest. And you don't have to. So I guess what I'm saying is this whole idea, like, we don't need to wait for the system rules to say you're now eligible for what the system has said is a palliative care specialist, or the palliative care unit, or the palliative care program. That's all tied to funding, and I get that, why we need boxes. But what you want is the approach. You want the information now to make the best decisions every single day moving forward, now that you know that she has a serious illness, and if it's an advanced cancer, what does that look like? What is the roadmap? You need to zoom out and keep asking, help me understand the big picture. Help me zoom out. Every illness has a beginning, middle, late, end stage. In the book, we give scripts. We're coaching. It's a how-to guide so that you can rebut the common responses. And essentially what I'm saying is, you do not need to only get a palliative approach and be in the know if you're getting care from a palliative care specialist. It's amazing if you get hooked into that system early, or connect with a hospice society, because they will know, how to do this dance. But if you hear some of these roadblocks, it's the language. So change the language, but you can get the approach, because that information, whether they know it or not, you can leach it out without the labels. That's what we are really trying to do, because we have heard people, when you have the context of the roadmap, and then what you get is time. And in that time, you can prepare, plan, use that precious time the way you want. That's what I didn't have when my mother died. We didn't know, and we didn't do the things. We were still going to school anyway. But and because of that, it's a normal chapter of dying. It's still sad, but there's still beautiful moments you can have, because you know how to make use of it. So that's what I wish for Catherine. And I hope that in our podcast or the book, or there are the tools to give you the script to leach out this information and be brave. We talk about invite yourself. There's a reason why, because there will be barriers. They will say things like, oh, you don't need that now, or you're not eligible yet. You're not sick enough. But that's not what you're asking for. So
Yeah.
keep at it.
Yeah. Yeah.
And I'm curious, like the guidance that you're offering, and the steps are amazing. And I think they're going to be a vast benefit. Some people have a really difficult time reaching out, communicating, talking, asking for assistance, or conveying their needs and their wants. Do you have any guidance or thoughts for those individuals or their family members on how to bridge that gap and speak with their clinician or speak with specialists so that they can better advocate for themselves? It's what they want, but that step is big.
Yeah, huge. Know your style. It's okay. That's chapter 3, which people were like, it could have been number 1 because your style is what drives the experience. There are people who, are more shy or are more reserved, or people who are, ask a lot of questions. There's no perfect style. So what know your style is all about is to know that, you kind of do a little bit of self-assessment, and those around you, those in your inner crew, then you've got to pair up, then mix and match. So if you know you're the kind of person who, really respects authority, is more quiet, that's my father. Then me and my brother know we need to go with him to appointments because he's not going to ask questions. He's not going to take notes. He's going to be like, oh, the doctor said everything's fine, right? No, we go with him. We take notes. We ask questions. We plan out our questions in advance. So that's where know your style is not just your style. It's also those around you. And if you know, there's no, again, if you're a very talkative, like a very control freak like myself, then you need to pair yourself up with someone who's going to help you enjoy the moment, be in the moment. You've planned enough now, enjoy, to take stock of what you have. So you're not always like, anxious about what's going to happen next and trying to make everything perfect. So there's ways to balance it out. And so my advice is in that chapter or in that, podcast episode, think about what your natural tendencies are. How you think that will play out with the illness you have. And then think about where there might be some pitfalls. Everyone will have a little bit of things where you kind of get in trouble. So how will you guard against that? You need to pair yourself up with someone. If you know you're a bit disorganized, you get overwhelmed easily, you're forgetful, get someone to be the manager to keep track, or ask someone who's really good at that to partner with you or be part of your inner crew and help with this task. So that's the way we talk about bringing people with appointments, if that's helpful, or, all that kind of stuff. Because that is the way we do this together. It's hard to do it alone. So we talk about, a team and mix and match.
Mm-hmm.
Thank you.
You talked earlier, Hsien, about, actually, no, you know what I did? I scanned the QR code during the presentation because it's so fun. It's like a little activity. One thing in there is test out exercises or workbooks, because I noticed there was a few questions in here, but where are you going with that?
Yeah, thanks, Claire. So I think that was this QR code is a remnant from the conference, but our hope is that this book, we do have little exercises and self activities, but I think we have a vision that there will be more, that we will co-design this roadmap, say, for a whole bunch of diseases with patients and families who have that disease, with the disease societies, with Health Canada, et cetera, so that, that roadmap that we talk about, we can actually create it together, say with people on this call, and then have that be a thing that you can bring to your doctor's office and go, where am I on the map? That's sort of the next step. So we're going, and then we would love, the opportunity to not just present, a webinar like this, but maybe this could be a course where we actually, or a book club where we actually do, go through the chapters and answer people's questions of how you actually do this well. So these are some of the things that we were thinking about that is in the realm of possibility. So if people sign up to our website, like, you can always unsubscribe, but it was just a way to communicate with people who are interested in this and to keep the dialogue going. I see there's a question from Catherine about regaining power, and it is just this idea of, so I don't want to take away your job, Kara. I just saw that, and I was just saying, it was just a thought that I have about when the loss of power happens because you don't know what to expect. And so all the power is in the health system to tell you what's next and how you're supposed to react. So if you can prepare or know what are the likely things to happen or what to look for. And then the other part of loss of power and loss of self is when there are decisions being made and you can't bring your values forward. So it's just like, I don't know, what's an example, but like birth, people have a lot of women have their birth plan so that it matches who they are, and they can imagine this idea of whether you want to have a water birth or a C-section. It doesn't always go, but as planned, but at least they've planned it out. They've talked about it. Some people have a doula that helps them, etc. So similarly with this process, this of being sick, not just dying, but being sick, like your values of what's important to you need to be front and center. But if you don't know to do that and match each decision to say, what am I getting? When doctors present stuff, they're trying to fix it, but they're not really asking you, how does that match? If you do that, what are you trading off? Like no treatment is an option. Or if I don't do the most aggressive thing, what are my other options? And what do I gain, but what do I also possibly give up? These are the kind of trade-off. There's always trade-offs. Those are the trade-offs you're making each step of the way. You just don't know it. And that's how you regain power in your sense of self, because then you're making decisions that match who you are, even if that's not what, the doctor would say. Or what, gives you the highest chance of living the longest. But that's not everybody's goal, especially if you have an incurable disease. So like living longer at what cost? Like, will that allow me to be present, alert, have quality time? I don't know the answers to that, but there are questions to be made. So that's the regaining power piece.
That's lovely. Thank you. There was another question from Diane. Any evening events in Canmore?
Yeah, actually, there's quite a few. They're putting us to work. So if you, I don't know them offhand, but I know that on Tuesday there's a public lecture in a library. But if you go to Bow Valley Hospice Society, they have all the events posted there. Or if you follow them on social media, I know they have a schedule, but their public events. There's a walk, there's a hike, there's an evening event. There's a couple things, I think. And if Bow Valley Hospice Society, I think there's one of them is in Banff and one is in Canmore. So that's where you might find that information.
Family. I'll just pop that right in here. Yes, there's a question about having access to the webinar. Yes, this will be posted on the Institute for Healthy Living and Chronic Disease Prevention site. I'm not sure how long, it doesn't take too long. I know Jennifer and Jaquetta are quick at that.
We'll try to have it up in short order here. It'll be about a day to two at least.
Yeah, okay. And there's another comment here from Greg. Enjoy how you speak to living to the end. That's a huge shift from a medical and disease lens to one of best wellness. Thanks for sharing this. This has been the biggest change to my practice over the past decade. And, Greg, you're really speaking to that. What I've noticed in the book and talking with Hsien is that you've been so mindful about flipping the language. In universities and academics, you might call this knowledge translation. I'm not sure. But tell me a little bit more about how you picked the imagery of the walking two rows. Like, how did that come about?
Oh, that's a great question. I mean, these metaphors were things that we tried out, and patients, families commented, and we changed. We probably had like 23 keys, and we were like, too many. So we ended up with 7, which apparently is odd numbers. It's 3s and are more sticky. But the metaphors were things that we tried out. We by presenting them as these are 7 that we sat around and we just came up with. But actually, it took us a long time to come up with them, because how do I say? It's not surprising to people on this call that when we talk about palliative care, it can be depressing and sad, and people, we had to find a way for it to be hopeful. And so these metaphors are things that Sammy uses, but also they were things that patients and families said, that one works and I get it. And it could be used upstream. The key wasn't just that it represented palliative care, but that it was something that could be done right away, early in an illness. Maybe not on the day of diagnosis, my goodness, that day you need to absorb it. But sometime after that, there is this, you need to understand what is the nature of your illness and what does that mean, and what happens after. And the more information you have, that's the powerful part. And I will say, as it seems that Greg is a clinician, but we talk about this on our podcast quite a bit, but clinicians are trained to fix things, to offer things, and only when there's nothing left to offer, it feels like they're giving up and they refer. But what we have learned is, or what we probably all know, is that just being there, journeying with someone, listening, caring, doesn't mean fixing. And patients and families want a caring system and caring healthcare providers. And information can be caring, realistic information, and helping people understand, adjust, prepare, live well with what they have is still an incredibly powerful thing. It probably is the most powerful thing they have, because the hope comes from planning for something that's is realistically going to happen, not for a wish that's like, unattainable. So so anyway, I think just reminding people that, sometimes just listening, silence, being with is a lot. It does not, you don't have to solve anything.
Yeah, and we have a couple of hospice societies on the line in training for volunteers, for our nursing staff. It often comes back to being versus doing, therapeutic communication, validating and holding space. And speaking of holding space, there's a comment you see from Diane. Do you have advice for how to hold space for the feelings that this brings up?
Yeah, particularly where we talked about these 7 keys, we realized was upstream. And so again, it could be for a stage 1 cancer or something that has a high likelihood of cure. But later on in the next 2 chapters, we talk about how do you know when time is running out? So this idea of the last year of life, not just the last weeks or months. And then we talk about demystifying dying, some of the myths around that. And Diane is absolutely right. Like, the idea of the mortality, like really facing that when the time is running out or when death is more close, can be difficult for people. And we aren't forcing people to get information that they don't want, especially if that's not their style or they prefer to, to live day to day, and someone else in the family is thinking about that. But we can share that people are often worried about listening to the end because they have preconceived ideas of what dying looks like. And ordinary dying, which is Catherine Mannix's book, and ordinary dying is actually a normal part of life. 100 years ago, people died in ordinary ways all the time. It is when medicine came in to try and, make us live longer in, very, complicated ways and wonderful ways as well, where we don't see it as often. It's become medicalized. So I think, of course, we need to respect people's desire for knowledge or when they're ready, but we do talk about, again, this idea of the value of knowing. Well, first of all, let's not imagine things that are not likely to be true. So let's demystify the myths that people think they will die of pain and they will, et cetera, and that's not very common at all. So let's find the reality of what that looks like. And again, if you do that early on, what will it look like? And it's not scary. Then we can talk about what will it look like for me? Am I there yet or not? And do I want to know when that time is or not? But if you really only had a year left, would you want to know if this was, your last year? I don't know. I cannot answer that for people. But me personally, I would want to know. I would live my life differently if I knew this was the last year I had. And so sometimes, again, knowledge is power, and it's the time. What you get is time and time to prepare. So I totally get that it is not easy to see people change or to lose that. But when people know, they actually make different choices, and the anticipatory grieving starts, which makes the survivors much better. Like, look, we see it in our podcast, the people who did it well, the stories they have after are totally different than the people who felt like a sudden death, because it's not sudden, it's to be expected. So yeah, of course, holding space, and there's whole kinds of things about grieving and how to be with, support people. And you can ask people, how would you like to be supported? If I do this, would that be helpful? These are all things that I'm sure, hospice volunteers are really good at. And this whole point is to try to help them find wonderful resources like yours earlier, and not just very close to end of life, or be like, why didn't I know this resource existed?
Yeah. Lovely.
Well, this brings us to the top of the hour. Dr. Seow, this has been totally amazing and insightful, from your presentation style to the knowledge and the wisdom that you've shared. On behalf of the Institute and Clara and our guests, thank you very much for contributing. I do want to let the guests know that following this, an online evaluation form will be sent to them. It would be great to have your feedback for future events and comments on this event. And alongside that, this event will be shared through our YouTube channel, and you can link to it on the Institute's website within the next few days. So thank you very much, everyone, for joining us, and enjoy the remainder of your day wherever you are. Take care. Bye now.
Bye-bye.